Welcome back. We saw previously when looking at drugs affecting the blood that at no point do you call these drugs blood thinners. There were two drugs, warfarin and aspirin, that were used as the classic examples, and we saw that they work by two completely different mechanisms of action but have the same outcome at reducing the coagulability of the blood in cases such as post-myocardial infarct. But we saw that warfarin depleted certain clotting factors and their production in the liver because it was an analogue of vitamin K, a necessary coenzyme needed in liver cells in the production of those particular clotting factors, but not all of the clotting factors. And we saw that aspirin worked via its usual actions at COX, but this time in platelets, and it had an irreversible action at that enzyme in platelets, ultimately meaning that the platelets were less aggregable. We'll now have a look at some disorders of the gastrointestinal tract. We will look very briefly at antispasmodics and agents that are used to prevent vomiting, antiemetics. For most of the time, we will concentrate on looking at treatments for gastroesophageal reflux disorder, GORD, and peptic ulcer disease, where we'll look at proton pump inhibitors, PPIs, and H2 antagonists, and we will also look at the effects of a couple of other agents in both of these disorders, antacids for one, and then cytoprotective agents and their important role in treating PUD, peptic ulcer disorder. In the upper gastrointestinal tract, we're interested in looking at the esophagus and stomach, but we will see that in peptic ulcer disorder it might include ulcers in the duodenum still caused by gastrointestinal by stomach acid, and by pepsin, the enzyme that's made active in the stomach. We'll also look at GORD, gastroesophageal reflux disorder, and nausea and the need for agents that will reduce nausea, prokinetics, and so on. In the lower gastrointestinal tract, there are many disorders: ulcerative colitis, Crohn's disease, two particular types of inflammatory bowel disease, and we'll see later that their treatment needs immunosuppressive therapy on occasions, and so we'll look at those pharmaceuticals in later sessions. Irritable bowel syndrome will have complications where the person might have other disorders elsewhere in the body, and so we'll look at the treatments of those. If it's treatment of the diarrhea or the constipation, we'll look very briefly at some of the treatments there, where the person might have predominantly constipation, predominantly diarrhea, or might vacillate between both of those conditions. But PUD, first of all, it is important to realise that your clients will need to be accessing Western pharmacy for the complete resolving of their peptic ulcer. That this is very important in preventing that relapse of the ulcer in future when we look at a particular bacterium that's associated with PUD. But it is also true to say that true preventative action of this Western pharmacy cannot occur if the client does not address certain key lifestyle issues, where they will most certainly need the assistance of natural healers to achieve those lifestyle changes. So number one important change that we will see for preventing peptic ulcers is to stop smoking, look at stress and underlying social issues,
there may be foods that are exacerbating the problem, and certainly reduction in alcohol intake. With natural healers in the healthcare team, very important role for helping the client to increase those foods that are going to promote the healing of that ulcer. And one key preventative measure is if it was originally caused by abuse of non-steroidal anti-inflammatories, or perhaps just within normal dosing, but because the person was chronically taking NSAIDs such as aspirin, to look at their causative role in peptic ulcers. So the organism that we will talk about is associated with peptic ulcers, but then there are those, as we'll see, where it's because the person is inhibiting prostaglandin production, the main mechanism of action of the non-steroidal anti-inflammatories. They are also reducing a protective prostaglandin in the stomach, and that this can then put them at great risk of developing ulcers. Similarly with GORD, gastroesophageal reflux disorder, it starts out as mild reflux, and with time and certain ongoing lifestyle practices, lying down after eating large meals, eating certain foods that relax the lower esophageal sphincter, such as a high intake of coffee or, unfortunately, chocolate, substances that irritate the mucosa, eating large meals, stress, and lack of exercise, other things that tend to affect lower esophageal sphincter tone and delay gastric emptying and gastric motility, such as having very, very protein-rich meals. All of these, including high fat in the diet, can put you at greater risk of GORD. So there will need to be natural healers involved in the healthcare team when we use Western pharmacy approaches and natural therapies to try and get the person to change those lifestyle habits, to eat smaller meals, to sit up at least 30 degrees. That's all it needs to be after meals. So it might be a client whose mobility is less. They may be in bed for much of their day except for when they do physiotherapy, but still to elevate the head at least that 30 degrees. Then cutting out coffee and spicy foods, other things that might irritate and reduce that lower esophageal sphincter tone. Cutting out the fats, the high fat content in the diet, and then modifying the amount of protein so as to increase that lower esophageal sphincter tone and keep the gastric contents in the stomach, always maintaining a higher pressure zone in the esophagus so you don't get reflux of the contents. But given all of those important lifestyle changes, in many people, the duodenal or stomach ulcer that they have is caused by hyperacidity and the presence of pepsin still active in that quite strong stomach acid. But this organism, Helicobacter pylori, a commensal organism found in many people, but it is also found that the risk of relapse of a peptic ulcer much greater if you are colonized with this organism, and prevention of relapse, better resolving of the ulcer, always seen wherever you can eradicate this organism. So we'll see that the Western pharmacy can be life-saving for your clients. It involves triple therapy, 2 antibiotics, and then one of these other medications that we'll look at, such as a proton pump inhibitor. It is important that these clients take this triple therapy for the full 7 days, that they miss no doses, that we achieve the most likely eradication of Helicobacter pylori with no chance of emergence of resistant strains. So this is another one of those areas where you use multiple antibiotic therapy so as to reduce the chance of emergence of a resistant strain. So the person is on the 2 antibiotics. Recurrence of the ulcer dramatically reduced. Resolving of the ulcer greatly increased if they can successfully do the 7-day triple therapy and the eradication of Helicobacter pylori. Some examples of some eradication regimens with the 2 antibiotics. Amoxicillin might be combined with clarithromycin, and then the particular proton pump inhibitor that's found in this brand, Nexium HP7, is omeprazole. So we'll look at how these drugs ending in azole, these proton pump inhibitors, do that role. There are other triple therapies. This one is Classid HP7, which is once again amoxicillin and clarithromycin, but omeprazole, a different proton pump inhibitor designed to eradicate this organism while also dealing with the hyperacidity issue. In gastroesophageal reflux disorder, we indicated that the pathophysiology was because of reflux of the gastric contents, the hydrochloric acid, but don't forget that pepsin, a protease enzyme, that will then invade tissue and help spread inflammation. So at that site where you get the reflux, you get a feeling of heartburn. Regurgitation of the contents, sometimes people can taste it at the back of their throat. And then various people show some atypical symptoms, referral of pain, and you would know that for some people they just experience a non-specific chest pain. They don't even know where to give as the source of the pain, and it could even for them be heart, lung, they cannot pinpoint. We have a chronic mucosal injury because of the chronic reflux of contents into the esophagus. We saw many risk factors, things that reduced the lower esophageal sphincter tone. But there are some other conditions to consider. People who are obese have this lower esophageal sphincter tone. This can also then lead to delayed gastric emptying. Then there are various conditions that will lead to increased acid production. There are certain agents that will directly irritate the esophageal mucosa, and even in just the elderly with their reduced swallowing capacity will have a lower esophageal sphincter tone and might be a greater risk of GORD. The long-term problem with this chronic injury of the mucosa is then of course metaplasia, a more sturdy tile-like epithelium laid down instead of the normal epithelium, or it might be quite columnar to provide better protection. And wherever there is metaplasia, one tissue type for another, and then ongoing chronic injury, the risk then of a dysplastic condition setting up in that tissue, which would be precancerous. With these people, they can commonly ascribe it to the gastric reflux if they get that regurgitation feeling in the throat, where they will then self-prescribe over-the-counter medications such as antacids. But some people can be on these antacids for many years before they finally seek assistance from a natural healer, where you advise them that perhaps antacids are just masking some more serious underlying problem, where you would refer them and get them to see a GP and get some endoscopy done to see if they have got these changes in their esophagus, this Barrett's esophagus by that stage. We'll see with GORD and PUD, if they don't respond to therapy short-term for GORD, it might indicate Helicobacter pylori eradication, but commonly that's in PUD where they will target that organism. Now they will use antacids, but generally you shouldn't be taking them for any longer than 8 weeks, and if something hadn't resolved by that stage, to seek medical help again. So here we would be looking at a couple of therapies that will help reduce the hyperacidity, H2 antagonists and the proton pump inhibitors, and then we'll look at various cytoprotective agents that will help the healing of the ulcer. If you have a look in detail at the antacids and start to build up some information about these in a drug diary that you'll compile, you'll see that they will just neutralize excess hydrochloric acid. This raises the pH of gastric contents, but as you can guess then that there might be less efficient digestion of their proteins. But this will certainly then reduce the amount of burning, but it doesn't stop those contents from still refluxing. Some of the agents, magnesium hydroxide and aluminium hydroxide in a common combination called Mylanta, do cause adverse effects, though they are very effective at neutralizing hydrochloric acid. So the magnesium hydroxide might produce a diarrhea, whereas the aluminium hydroxide might produce a constipation. So it's hoped that the two mineral salts in that preparation will counteract each other. There are those that are carbonates and produce carbon dioxide, as the carbonate neutralizes the hydrochloric acid. Some people get quite addicted to that burp because they know once they have burped, that relief from that reflux and burning will be happening soon. It's important to note though that with these antacids that there is no resolving of an ulcer, and certain changes in the esophagus once again will resolve with time, but probably only if there is a better addressing of the issue than just abusing antacids for several years. So they do have some very serious drug interactions of a pharmacokinetic nature. They will affect the absorption of a whole range of drugs, where you then might be told, if you are taking antacids, that you should do so 2 hours before taking other substances such as antibacterials, tetracyclines, particularly quinolone, antibiotics, but many other drugs whose absorption will be affected by the quite alkaline nature of antacids. Also, because magnesium Mg2+ binds to certain drugs, it will affect their absorption. We'll see this also with iron when taken as an oral medication, because of its Fe2+ nature, will affect the absorption of many drugs. So then the next class or subclass of drugs used to treat PUD and GORD, the H2 antagonists. Their particular target in the body is a receptor for histamine, but of the H2 type. This type of receptor is found on parietal cells, the cells that are actively secreting hydrogen ions and chloride ions. When you block that receptor, there is decreased production of that hydrochloric acid. Pepsin then just becomes less active because it's not at its optimal pH. And so once again, H2 antagonists needed to help resolve symptoms, but there may be problems with nutrition and digestion of proteins in the meantime. Some examples of H2 antagonists, you can see that they have a common ending to their name. They all end in tidine, tidine. So we have ranitidine, Zantac, and svetidine, Tagamet, two common examples of H2 antagonists that you will find your clients on. But we stress once again that it should only be for short-term use at reducing acid while you help resolve the underlying physiological changes. The efficacy of these is greatly reduced if the client drinks alcohol, so you may be involved in trying to achieve lifestyle changes for this person and in the hope of getting a better resolution of the underlying GORD or the peptic ulcer. As with any medication, the H2 antagonists have adverse effects in the gastrointestinal tract and in the CNS. The H2 antagonists are avoided in the elderly who already produce far less hydrochloric acid. They do interact once again with a range of other drugs, and there is a pharmacokinetic interaction, cimetidine inhibiting certain CYP, a system of isoenzymes, and because the metabolizing enzymes are decreased, the levels of these drugs are higher in the plasma, so there's a greater risk of adverse drug reactions and toxicities. Also, there are some drugs that need an acidic environment to be absorbed, and their bioavailability will be affected then while the person is on this drug which reduces hydrochloric acid levels. Excretion via the urine is important, and so for people who do have impaired renal function, there may be a warning on the use of H2 antagonists. Proton pump inhibitors likewise might be used to control levels of hyperacidity. You saw a part of triple therapy with 2 antibiotics to help encourage the clearing of the Helicobacter pylori organism using the antibiotics, and then the resolution of the ulcer while you are producing less protons, so that's the hydrogen ion. Here there is a particular protein, an enzyme called H plus K plus ATPase. It's a proton pump. It uses ATP to actively transport the hydrogen ions into the exocrine secretion secreted at the surface of those gastric parietal cells. The drugs, the PPIs, those that end in AZOLE, but more importantly it tends to be PRAZOLE, a common ending, are non-competitive, but they do bind irreversibly to that ATPase, the proton pump, and their duration of action can last days. We'll see the advantage of this then is that you don't need constant dosing, that it can be a regime of dosing of 1 day only. So some examples: lansoprazole, which is Zoton, and omeprazole on its own, Losec, and you saw it in use in a couple of triple therapies under other brand names. So these would be indicated if there was peptic ulcer disorder that you wanted resolved, or if because of the GORD there was severe erosion of the esophagus and quite extensive inflammation as seen in endoscopy. If a person has a hypersecretory condition called Zollinger-Ellison syndrome, then they may be on a proton pump inhibitor long term to try and resolve that illness. Once again, these are less efficacious if the client drinks alcohol, so they are encouraged to try and limit the amount of alcohol. Because we're actually inhibiting the pumping of hydrogen ions, the person could become quite achlorhydric, meaning that they aren't producing near enough hydrochloric acid for digestion. And there is the possibility of a hypergastronemia, high levels of gastrin hormone in the blood. Because of these changes, it's recommended once again that a person isn't on proton pump inhibitors for long periods of time, 8 to 12 weeks only, similarly as it was for H2 antagonists, and remember similarly for antacids. But the unfortunate thing with antacids, that being over the counter, the person can keep self-prescribing for longer than that 2 months or 3 month period. So also to help resolve a peptic ulcer, a person might be given a cytoprotective agent. There are 2 types. One that actually works at the body's own levels of prostaglandin. It produces an analog hormone. This particular type of cytoprotective agent, the one that is a synthetic prostaglandin, is a synthetic PGE1, and it's misoprostol, sold under the brand name Cytotec. If a person doesn't have Helicobacter pylori because their ulcer was actually caused by a lack of prostaglandin, inhibited because of the chronic use of non-steroidal anti-inflammatories that deliberately target prostaglandin production, well then these cytoprotective agents might be indicated there. Being a hormone analog, they do have some serious adverse effects throughout the body, and because they are a synthetic hormone acting on uterine smooth muscle, they're restricted in women of childbearing age. There are some various cardiovascular and cerebrovascular issues too with their use. A different type of cytoprotective agent is one that forms a raft over the site of the ulcer. The type of cytoprotective agent here is sulfated sucrose with aluminium hydroxide, which you saw was one of those antacids. This also has the added effect of stimulating your own endogenous prostaglandin, causing you to then produce the normal mucus, which is cytoprotective. But where that sulfated sucrose and the aluminium hydroxide encounter hydrochloric acid, you get the formation of a protective gel over the site. This creates a barrier and rafts the ulcer crater so as to protect it. Sulfated sucrose is abbreviated then to sucralfate, sold under the brand names Carafate and others, but once again effective and efficacious, but it should only be used for short-term therapy to resolve symptoms. Once again, serious adverse effects. There will be many drug interactions because they are aluminium hydroxide. Certain drugs, as you saw, that require an acidic environment for their absorption and for their bioavailabilities. The sucrated sulfate could also lead to constipation, back pain, and, as with many medications, allergic reactions such as a rash. So here in summary are the drugs used for peptic ulcer disorder, showing you their site of action, where here we have the lumen of the stomach, where ultimately we want to pump hydrochloric acid made by the parietal cell, as shown here. These cells also manufacture pepsin as pepsinogen, which will only become activated as pepsin enzyme here in the lumen, where the pH gets up high enough. We said that sulfated sucrose acts as a raft, covering over the site of an ulcer, where the aluminium hydroxide and the sulfated sucrose set up a gel at that site of excess hydrochloric acid production. But to actually reduce the levels of hydrochloric acid, there were 2 Western pharmacy targets. First of all, on that parietal cell, it's H2 receptor, or it's ATPase, the proton pump. So the H2 antagonists worked at reducing histamine's actions on those parietal cells, at increasing hydrochloric acid production, and omeprazole, lansoprazole, and all of the other proton pump inhibitors acted here directly at the proton pump where they didn't competitively bind. They were non-competitive and irreversible binders to the particular ATPase enzyme. The cells that produce the histamine in the gastrointestinal tract are your enterochromaffin-like cells, and we'll be talking about them in later sessions when we look at some amazing connections between the gastrointestinal tract and the CNS, though the gastrointestinal tract has its own nervous system, the enteric nervous system. So as shown there, this histamine then affects the parietal cells at increasing hydrochloric acid production. Antacids merely neutralized that excess hydrochloric acid production but didn't target the source of the problem, where we saw it was important all along for that person to address. If they have colonization with Helicobacter pylori, if they have been taking NSAIDs chronically and as an adverse effect have developed ulcers because they can't produce enough protective prostaglandin of their own. Then we saw that there was a Western pharmacy to help heal a peptic ulcer by taking misoprostol, a synthetic prostaglandin E1 analog. The advantage of taking the sucralfate and the aluminium hydroxide is it encouraged the production of your own endogenous prostaglandin and production of your own endogenous mucus. Very quickly we'll look at antispasmodics, agents that stop any spasming of smooth muscle, particularly where a person might be constipated or obstipated. But these antispasmodics not only act in the small intestine and large intestine, they will have actions on bladder and uterus and other smooth muscle. Oftentimes, antimuscarinic drugs are used, and we'll be looking in more detail at the mechanism of these antimuscarinics at that muscarinic receptor. So if you haven't yet reviewed the physiology of the parasympathetic nervous system and those muscarinic receptors, then make sure that you have a look at that so that you can understand the actions of drugs such as mebeverine, which is sold under the brand name Colac. Anywhere where we have intestinal smooth muscle spasm. And propantholine, sold under the brand name probanthine, can be used as an adjunct in peptic ulcer disease to help manage the symptoms. Now, in both cases, there is a significant crossing of the blood-brain barrier into the CNS to affect the vagus. It only has its actions peripherally at the vagal postganglionic receptor. Then to look at emetics and antiemetics. Emetics we'll look at later when we look at opioids, but here looking at substances that will help treat vomiting and nausea. We'll also look at, in more detail when we look at antineoplastic agents, one of the common adverse effects of the antineoplastics is severe vomiting and nausea. So have a look now, and you'll return to this particular class of drugs in more detail when we do look at those antineoplastics. So there are many targets for these antiemetics. Corticosteroids themselves have an antiemetic action, and we'll see that they are used for many reasons in treating cancers, but one action will be the reduction of nausea caused by the antineoplastic agent. It's unknown as yet why corticosteroids have that antiemetic action, but it could perhaps be at 5-hydroxytryptamine or serotonin receptors, more affecting their turnover in the CNS. For migraine, antiemesis we've seen that we use drugs that act at 5-hydroxytryptamine receptors. There were two parts to a migraine. There was vasoconstriction, when the person experiences an aura, and then at the time of the incredibly thumping headache, that was a vasodilation and a vascular spasming at that point where you want to block the vasodilation. So prophylactically, 5-hydroxytryptamine antagonists were used to block the vasoconstriction in the early stages of the migraine, but once an acute migraine has already started, then you try and block the vasodilatory actions of the vessels by giving a vasoconstrictive. So you give a 5-hydroxytryptamine agonist. So a change in therapy when you're trying to prevent the migraine to when you're trying to treat the acute symptoms. Thalidomide was sold as an antiemetic and a sedative drug in the 60s, but that led to the disastrous appearance of its teratogenic actions on the developing limb buds in the fetus. So it's avoided now at any cost in pregnant women, but we will see that it does have some uses in some very rare cancers as an immunosuppressive. It's used in people with HIV, but once again, when there is clearly no chance that that person, if female, would be pregnant. So the mechanism of action of thalidomide at affecting vomiting and reducing it was its sedative actions in the CNS. Commonly now, for a person with vomiting and diarrhea, or nausea and vomiting caused by antineoplastics, they'll be given a prokinetic, something that will speed up the movement of the contents through the stomach so as to make it less likely that they will get a vomiting signal. So the classic one is metoclopramide. It does have actions in the CNS, but its prokinetic action targeting emesis and reducing it is a direct action on the stomach. But it does affect the chemoreceptor trigger zone. I know some of you were reviewing that and its physiology when you were looking at the neurotransmitters, particularly looking at dopamine at D2 receptors. So go back and have a look at that CTZ. You'll then understand when you see that metoclopramide has extrapyramidal adverse effects because it affects dopamine receptors. There are some very rare extrapyramidal effects similar to those seen with antipsychotics, and this dystonia of muscle is irreversible and so needs to be avoided. There are other antiemetics. Ginger will also be antiemetic, but it will also enhance gastrointestinal motility. That may be a good thing, that may give it a prokinetic action, but ginger, you also need it to be aware, interacted with warfarin and other antiplatelet treatments. This is seen in vitro. It would require further testing to see if that is clinically significant.